Okay, can you hear me? Can you?
You are
Can you
here,
hear me,
Jonaki.
please?
You can
Okay.
start.
Okay, ladies and gentlemen, Assalamu alaikum and good evening. I, Dr. Jannatul Firdaus, Scientific Secretary of Gynecological Oncology Society of Bangladesh, welcome all of you to the 6th International Virtual CME on Overview on Histopathological Spectrum of Cervical Lesions and Researches. Today, we are delighted to have Professor T. Choudhury Sir, immediate past President of GOSB, as chief guest, and Professor Sabera Khatun Madam, President of GOSB, as chairpersons. We are pleased to have as panelists Professor Laila Arjuman Banu, Chief Consultant, Ops and Gynae Department, Labit Specialized Hospital, Dhaka, Professor Gholam Mustafa, ex-head Department of Pathology, National Institute of Cancer Research and Hospital, Professor Dr. Rehana Parveen, Senior Consultant, Gynecological Oncology, Square Hospital, Dhaka, and Dr. Farida Arjuman, Head and Associate Professor, Department of Histopathology in ICRH. Today, two renowned faculties joined us as speaker, one national and one international faculty. International faculty is Dr. Divya Midha, Senior Consultant, Department of Oncopathology from Tata Medical Center, Kolkata. And another speaker, Professor Dr. Jillur Rahman, Chairman, Department of Pathology, Bangabandhu Sheikh Mujib Medical University. Without further delay, I like to hand over by mic to today's moderator, Dr. Kashifa Khatun, Organizing Secretary of GOSB, to conduct the session. Dr. Kashifa, please.
I am delighted to be here. Respected Professor, distinguished guest and learned audience, Assalamu alaikum and very good evening. I am Dr. Kashifa Khatun, Associate Professor, Department of Gynae Oncology from National Institute of Cancer Research Hospital, welcoming you all to our 6th International CME on Overview on Histopathological Spectrum of Cervical Lesion and Researches. Cervical cancer is the most commonly diagnosed cancer in 23 countries and is the leading cause of cancer death in 36 countries. The individual organ within the genital tract make up an extended Mullerian system that can give rise to a wide variety of histologically similar tumors and be problematic for tumor classification and assignment of primary site. So we have focused this topic today. The program will be chaired by Professor Sabera Khatun, President, Gynae Oncology Society of Bangladesh and Founder Chairman, Gynae Oncology, Bangabandhu Sheikh Mujib Medical University. We are lucky to have Professor T. Choudhury, eminent past President, Gynae Oncology Society of Bangladesh, as the chief guest. With the permission of Honorable Chairperson, I am going to start the program organized by Gynae Oncology Society of Bangladesh. The program will be telecasted live in Facebook and Dr. Stubby, I am requesting to share it. Now I would like to request Professor Najma Haq, Secretary General, Gynae Oncology Society of Bangladesh and former head, Department of Gynae Oncology, Dhaka Medical College Hospital, to give welcome speech.
Thank you, Dr. Kashifa Khatun, for giving me this opportunity. I'm Professor Najma Haq. Now I start to say some welcome address. Respected chairpersons of our today's webinar, now we see the webinar on the overview of histopathologic spectrum of the cervical lesion and research. The chairperson, Professor Sabera Khatun, who is the president of GOSB and the founder chairman of Gynae Oncology Department of the BSMMU. Chief guest, our honorable legendary professor, the professor of Gynae, Professor T. Choudhury, who is the teacher of our teachers and also the immediate past president of GOSB. Learned speakers, Dr. Divya Midha, who is the Senior Consultant, Department of Oncopathology, Tata Memorial Center, Kolkata, India, and Professor Jillur Rahman, Professor of Pathology, BSMMU, Dhaka, Bangladesh. Panel of experts, Professor Laila Arjuman Banu, Chief Consultant, OB/GYN, Labit Specialized Hospital, Professor Gholam Mustafa, ex Head of the Department of Pathology, NICRH, and Professor Rehana Parveen, Senior Consultant, Gynae-Oncology, Square Hospital, Dr. Farida Anjuman, Associate Professor, Head of the Department of Pathology, NICRH, and also the moderator, Dr. Kashifa Khatun, the Organizing Secretary, GOSB, and Professor Jannatul Firdaus, Secretary General, GOSB. Dear participants joining in this webinar, Assalamu alaikum and very good evening today to you all. It is
Thank
my
you.
It is my great pleasure to welcome you all to this webinar on the overview of histopathology spectrum of the cervical lesion and research. Today, we have gathered here to learn from each other, exchange ideas, and exchange our knowledge and skill in the field of cervical pathology also. We will hear from experts who will discuss the various cervical lesions, their clinical features, and the histopathologic association with them. Our goal is to provide you with an depth and understanding the current status of the knowledge. And in this field, the webinar will also highlight the challenges faced in the diagnosis and management of cervical lesion, particularly in low resource setting. So hopefully this webinar will enlighten our insight about histopathologic spectrum of the cervical lesion and research. Thank you, all of you, to join us, and we look forward to an engaging the informative session. Thank you again. Allah Hafiz, Joy Bangla.
Thank you, madam, for your nice speech. Now I am requesting our chairperson of today's session, Professor Sabira Khatun, President, Gynae-Oncology Society of Bangladesh, to give introductory speech.
Thank you, Dr. Kashifa Khatun. I'll not give too much lengthy introductory speech. Just I want to say something about the histopathology, why we have selected this topic for CME. Because the cervical lesions are so critical that without knowing the histopathology of the cervical lesions, treatment is often inaccurate. So I think that every gynecologist, not only the gynecological oncologist, every gynecologist should know the histopathological spectrum of cervical lesion. There are big spectrum of cervical lesions, starting with some benign lesions up to the frank malignant cervical cancer. And there are spectrum of histopathological spectrum of malignant lesions of cervix. So we should know that all gynecologists should have a knowledge about the histopathological aspects of cervical lesions and where we are, whether we are sufficiently enriched to give the histopathological reports. This should be known to everybody, every gynecologist. So this topic we have selected for this presentation and for discussion by our learned panelists. We'll hear opinion of our learned panelists about the histopathological spectrum of cervical lesions. Thank you very much. You can, Dr. Kashifa Khatun, you can now call our first speaker about the histopathological overview on histopathological spectrum of cervical lesions. Thank you.
Now I would like to welcome the presenters to deliver the presentation. Today we are privileged to have two learned speakers from home and abroad. Our first speaker, a very special guest, Dr. Dibba Midha. She is Senior Consultant, Department of Oncopathology, Tata Medical Center, Kolkata. She will sharing with us her expert opinion regarding overview on histopathological spectrum of cervical lesion. Now I am requesting to deliver the presentation.
Good evening, everyone. Shall I share my screen, madam?
Your screen is not visible, ma'am.
I'm sharing it. Is it visible now?
Yes.
Is my full screen visible?
Yes, madam. It's visible.
Okay. Just 1 minute. Am I audible?
You are audible.
Good evening, everyone. Greetings from Kolkata. Today it's a very pleasant, rainy evening in Kolkata, and I hope that the showers have brought good weather and cheer to Bangladesh as well. At the outset, I would like to thank Professor Jannatul Firdaus, Professor Sabera Khatun, Professor Nazma Haq, and all members of Gynecological Oncology Society of Bangladesh for having me here. And of course, a very big thank you to Dr. Jayati Bhaumik, Head of the Department of Gynae Oncosurgery at Tata Medical Center, with whom I collaborate and work on a day-to-day basis. So just hold on. So the topic given to me is the overview of histopathological spectrum of cervical lesions. And over the next 15 minutes, because of paucity of time, I'll be concentrating on the carcinomas or the epithelial lesions, and I'll be highlighting on some updates in cervical pathology pertaining to the cervical epithelial lesions. All right. So we all know that cervical epithelial pathology and its neoplastic consequences is dominated by HPV infection. And HPV infection has traditionally been considered necessary for the development of cervical carcinoma. However, it is becoming increasingly recognized that a significant proportion of cervical carcinomas, particularly adenocarcinomas, are not associated with HPV infection. Moreover, as in other anatomical sites like the oropharynx and vulva, where HPV-independent lesions have been described, the HPV-independent cervical carcinomas are generally more aggressive than the HPV-associated carcinoma, and this property is of increasing clinical importance. So this is the latest 5th edition of the WHO classification of female genital tumors, which was published in 2020, and it differs from the previous edition. Number one, it's thicker. Number two, it's more blue than the previous blue book. But more interestingly, when it comes to cervical lesions, it divides cervical epithelial tumors, not only the carcinomas, but also the precursors on the basis of their association with HPV infection or on the basis of not being associated with HPV, and they are divided into HPV independent lesion. So this change produces a classification that will allow more accurate assessment of the role of HPV testing in cervical screening programs, as well as the role of HPV vaccination. So if you can see from this table, I would like to use my pointer. Right. If you can see the pointer on the screen, the cervical tumors and the precursors are divided into squamous and glandular. So those resembling the squamous epithelium are the squamous tumors, and those resembling glands are the glandular tumors. Now, the squamous tumors are divided into HPV associated and HPV independent. Those that are linked to the HPV virus are HPV associated, and those that are not linked to HPV virus are the HPV independent. Now, if the glandular lesions also on the basis of the HPV association is classified into HPV associated and HPV independent. Now, let's look at these lesions more closely. So when it comes to the squamous lesions, we know that there are precursor lesions and there is squamous cell carcinoma. Now, squamous cell carcinoma is a very common diagnosis in the cervix. HPV-associated squamous cell carcinoma and HPV-independent squamous cell carcinoma, you cannot distinguish them on the basis of morphological criteria alone. You need, so morphologically, whether it's HPV associated or HPV independent, in general, by morphology, you cannot classify. You need P16 IHC, or which is a surrogate for HPV infection, or you need another method like an HPV, a direct method like HPV in situ hybridization to distinguish the two. Now, if you know that the percentage of HPV-independent squamous cell carcinomas in the cervix is very, very low, up to 7%. And currently, there is no difference in treatment between HPV-associated and HPV-independent tumors. However, it is recommended that the type of cervical SCC, whether HPV-associated or HPV-independent, should be documented on the pathology report. And we do this by using the P16 IHC, which is considered to be the surrogate of HPV infection. Now, suppose you don't have P16 IHC in your lab, it doesn't matter. You can give a morphological diagnosis without differentiating the two categories, and this is an acceptable alternative where the facilities necessary to make this distinction is not available, because at present there is no difference in treatment between HPV-associated and HPV-independent tumors. Now, coming to the precursor lesions of squamous cell carcinoma, that is the LCIL and the HCIL. There is no evidence that these precursors are HPV independent, and therefore squamous intraepithelial lesions or the precursor lesions of squamous cell carcinoma are grouped into a single HPV associated category. By this I mean that for the precursor lesions, they are all HPV associated. It is the squamous cell carcinoma which can be HPV associated or independent, and the incidence of HPV independent squamous cell carcinomas are very low. Now, this is a typical squamous cell carcinoma of the cervix. This is the one which is showing the polygonal cells arranged in sheets and nests. They are squamoid in appearance. Any pathologist who's sitting in the panel will know that this is a squamous carcinoma, particularly because it is associated in this particular case with keratin formation. So this is a squamous cell carcinoma, which is a keratinizing one.
Recording in progress.
Now, the second photomicrograph is an example of an invasive squamous cell carcinoma. But if you can see the difference, this keratin which is present in this particular photomicrograph is not present over here. So this is an invasive squamous cell carcinoma which is non-keratinizing. This picture shows the P16 IHC, which is used to distinguish between HPV-associated SCC and HPV-independent SCC. So this is a P16 IHC, which is showing block positivity in the squamous cells. By block positive, I mean every cell is strongly and diffusely nuclear and cytoplasmic positive for P16, and this is known as the block positivity. If you see block positivity for P16, it means that this is HPV associated, because P16 is considered to be a surrogate marker for HPV infection. How does P16 negative look? Let me tell you, there is nothing called totally negative. The tumor can be patchy or weakly positive. That doesn't make it block positive. Only if a tumor is P16 block positive, like this picture, do we say that it is HPV associated. Now let us come to the glandular lesions. The glandular lesions have attracted a lot of importance, and the reason is that though the HPV-associated glandular lesions are more common, there is an increasing number of HPV-independent glandular lesions. Now, unlike the precursors of squamous cell carcinoma, the precursors of adenocarcinomas of the cervix are divided into HPV-associated and HPV-independent. So AIS is adenocarcinoma in situ is an HPV-associated precursor lesions, whereas atypical lobular endocervical glandular and gastric type adenocarcinoma in situ are HPV-independent glandular precursor lesions. So let's come to adenocarcinoma in situ, which is an HPV-associated precursor of endocervical adenocarcinoma. Now, what do you mean by in situ? So in situ means a lesion which is limited to the epithelium. It's an intraepithelial lesion. Please follow my cursor or the pointer over here. This is a lesion which is limited only to the epithelium. This is the underlying stroma, which you can see there is no invasion into the stroma. Therefore, it is an in situ lesion limited to the lining epithelium. It's a glandular intraepithelial lesion without any stromal invasion. If you go to high power, you can see that these glands, they are limited to the lining. They are pseudo-stratified. That means it is multiplying the cells. They are showing stratification. They are not in a single layer like a normal endocervical gland. The nuclei are hyperchromatic or dark. There is easily identifiable mitotic figures in the apex. These are mitotic activity. And there is a lot of apoptosis or karyorrhexis or cell death at the base. How do we know that this is HPV associated? Again, as I said, if you do the P16 IHC, you can see this block positivity in the lining epithelium. Please note that there is no tumor in the stroma. Instead of P16, which is an indirect method, one can also use a direct method, which is the HPV in situ hybridization using highly sensitive methodology. But P16 IHC is a very easy stain to standardize in your labs. At TMC Kolkata, we use P16 IHC, and we've been doing that for the last 12 years. The stain works beautifully, and it's a very, very important IHC marker in the diagnosis of cervical carcinoma. This is another picture showing you the P16 block positivity. By block, you mean every single nuclei are positive. But what are these glands in the stroma? Is this invasive? But they are not showing any P16. These are the normal endocervical glands which lack the block positivity, which is seen in the overlying glandular epithelium. So this is not invasion. This is adenocarcinoma in situ, HPV associated, which is showing P16 block positivity, and the normal endocervical glands are P16 patchy or negative. So now coming to the HPV associated endocervical adenocarcinomas. This is a typical endocervical adenocarcinoma, which is HPV associated. In this example, there is a lot of apical mucin. In this example, it is less mucinous or non-mucinous. If we did the P16 IHC, there is block positivity for P16, which indicates that this is HPV associated. If you do the HPV in situ hybridization by which is a direct method, you can see these positive nuclei. So P16 is a surrogate marker, and HPV-ish is confirmatory for the HPV association. Please remember that endocervical adenocarcinomas are negative for hormone receptor markers, that is ER and PR. Now, a very important differential diagnosis is endometrioid carcinoma. Sometimes you have an endometrial carcinoma, which is in the lower uterine segment. And at that point, if a biopsy is taken, it is very important that you distinguish it from an endocervical adenocarcinoma, because the treatment protocols are entirely different for an endometrial carcinoma, and the treatment is very different for an endocervical adenocarcinoma. So this picture over here is an example of an endometrial carcinoma. The P16 is not block positive. There is some brown staining, but there are many areas of negative staining. As I said, there is patchy staining. Patchy staining is not equal to block positivity. And we can say in this case that P16 shows lack of block positivity and there is no HPV association. Please note ER and PR. ER and PR are positive. So this particular case is an endometrioid carcinoma, whereas the previous case that I showed you, which looks morphologically very similar, is an endocervical adenocarcinoma with P16 being block positive and ER and PR being negative. Now, this table gives you a very good idea between an endometrioid carcinoma and an endocervical adenocarcinoma. As I stressed earlier, clinically it is very important for the pathologist to make the right call because the treatment protocols are different. Grossly, an endometrioid carcinoma, the bulk of the tumor is in the endometrium or in the lower uterine segment, where it could be associated with Lynch syndrome. In case of endocervical adenocarcinoma, the bulk of the tumor is in the cervix, leading to a barrel-shaped cervix. Microscopically, an endometrioid carcinoma has atypical hyperplasia in the background or an EIN in the background. There are squamous morules. There are tall columnar cells with stromal foamy histiocytes. In case of an endocervical adenocarcinoma, the precursor is an adenocarcinoma in situ with intracytoplasmic mucin, goblet cells, as I said, floating mitosis and basal apoptosis. But sometimes microscopically, it is very, very difficult to distinguish an endometrioid endometrial carcinoma from an endocervical adenocarcinoma. In that case, immunohistochemistry comes to the rescue. An endometrioid carcinoma is ER and PR positive. It lacks diffuse strong positivity for P16. It's positive for Vimentin and negative for CEA. In contrast, the endocervical carcinoma is negative for ER and PR. It shows diffuse strong block positivity for P16, as I showed you in the previous images. Vimentin is negative and CEA is positive. Now, having looked at adenocarcinoma in situ, the HPV associated, there is an increasing trend for HPV independent glandular lesions, and AIS or adenocarcinoma in situ of the HPV independent type include the lobular endocervical glandular hyperplasia and the gastric type adenocarcinoma in situ. This again is a non-invasive glandular neoplasm. By non-invasive, I mean it is limited to the epithelium, as I showed you before, but unlike the HPV associated, these lesions are not related to HPV virus. In fact, they are related to another pathway, maybe a P53 pathway. And gastric type differentiation, which mimics a gastric type epithelium, is characteristic. This is a low power view showing the normal endocervical epithelium, but in this particular gland, if you see, is more blue than this gland. The reason is it has been involved by adenocarcinoma in situ. A closer view, this is, let me just hide this. Hide it, right. The video panel is not hiding. Okay, doesn't matter. This particular gland over here is blue over here or normal over here, light blue, and here it is showing pseudostratification and is involved by adenocarcinoma in situ. This lesion was P16, lack of block positivity, so it is HPV independent. All right. Now coming to the adenocarcinomas, which arise from probably the precursor lesions, which are HPV independent. There is an increasing trend towards these HPV independent lesions, and pathologists should be able to diagnose these lesions, and the clinician should be able to recognize these lesions on a pathology report. So the common HPV independent carcinomas, the most common type is the gastric type, followed by the clear cell and the rare mesonephric type. What is a gastric type HPV independent adenocarcinoma? It represents the most common type of HPV independent adenocarcinoma. So it's not that rare. It's 10% of all adenocarcinomas. It shows a gastric or a pyloric differentiation and is unrelated to HPV infection. The reason this is important is for a pathologist that this will not show block positivity for a P16, and you should be aware of this lesion so that you don't call it an endometrial lesion or don't call it a mets from the stomach. So you should know that there are lesions in the cervix which can mimic a stomach kind of an epithelium or a gastric epithelium or a pyloric epithelium, which is unrelated to HPV infection. This lesion was formerly called the minimal deviation adenocarcinoma or the adenoma malignum. It features an epithelium with foamy, clear to eosinophilic mucinous cytoplasm. It is negative for ER and PR and expresses this unique marker called HIK1083, which is a marker of pyloric type epithelium. We don't have this marker in our laboratory. Basically, you don't need it. If you know of this lesion and if you know that they are HPV independent and you have the P16 immunostain in the lab, this is going to be used in making this diagnosis. Now, this gastric type HPV independent adenocarcinomas are P53 mutated and P16 negative or patchy, and therefore they are HPV independent. And they look like have a pyloric type epithelium. Now, there is also some rare tumors like clear cell carcinoma, which has clear or eosinophilic cytoplasm. And these cells are arranged in a tubulocystic, papillary, or a solid pattern, just like the clear cell carcinomas of the endometrium. Please remember, they are negative for ER and PR, and they are negative for P16 or HPV-ish. This is a typical clear cell carcinoma of the cervix, which is HPV independent. Another rare lesion is the mesonephric type adenocarcinoma of the uterine cervix. It is called mesonephric because it is said to arise from the mesonephric remnants in the cervix, and it shows mesonephric or a Wolffian differentiation. It looks a little different because it shows many architectural patterns like glands, ribbons, trabeculae. It's a very blue tumor. P16 is not diffuse block-like. It can be negative or patchy. How do you make this diagnosis? Is when you see adjacent normal mesonephric nests or mesonephric hyperplasia, and this has a very unique immunophenotype. It shows positivity for GATA3 and TTF1, suggesting a mesonephric differentiation. They are negative for ER, and therefore you can distinguish it from endometrioid carcinoma. They are negative for napsin, so you can differentiate it from clear cell carcinoma. And of course, they are negative for or patchy positive for P16. They don't show block positivity for P16. Therefore, they are HPV negative or HPV independent. So this is a typical mesonephric carcinoma, which is HPV independent. It's a new kid on the block. One should be aware of this diagnosis. It is showing the typical mesonephric appearance of a very blue tumor with these intraluminal colloid-like secretions. Here it's showing glands, then there are some papillae. In other areas, it can show solid areas, trabeculae, various architectural subtypes. Now, what are the other adenocarcinomas of the cervix? True endometrioid carcinoma of the cervix is a very, very rare entity. It can arise from a background of endometriosis. It should be diagnosed only when you have excluded an endocervical carcinoma, as I showed you in the table, or you have excluded an endometrioid carcinoma of the endometrium extending to the cervix secondarily. So it's a very, very rare diagnosis of a primary endometrioid arising in a background of endometriosis in the cervix. It's a rare possibility. Now, coming to serous carcinoma of the cervix, do they exist? This has been removed from the WHO 2022 classification, as there is no evidence that it occurs as a primary tumor. It can extend from the lower uterine segment or from the endometrium or the uterus down to the cervix, but primary serous carcinomas of the cervix does not exist and therefore has been removed. Now, adenocarcinoma NOS, not otherwise specified, has also been removed because it is encouraged that pathologists should assign cervical adenocarcinomas to the HPV associated or to the HPV independent categories. The reason is the HPV independent categories behave in a more aggressive manner and have a worse prognosis than the HPV associated adenocarcinomas. Now, what else is new in cervix pathology? There is something called, I'm sorry, did I stop sharing? I'll just, yeah. Can you see my screen now?
Yeah, screen is visible, ma'am.
You can see my screen? Yeah.
Screen is visible, ma'am.
Okay. So what else is new in cervix pathology? If you look at the CAP protocol for the reporting of cervical adenocarcinomas, there's something called the Silva system of invasion. This tells you that it's very difficult to measure the depth of invasion of adenocarcinomas, and there is a new Silva system of invasion or a pattern system of invasion applicable only to HPV-associated invasive endocervical adenocarcinomas, where it's been categorized into pattern A, pattern B, and pattern C. So the Silva A is this one, where you see no destructive stromal invasion, a preserved lobular architecture, well-demarcated glands with rounded contours, and no LVI. These tumors have a very low propensity for lymph node mets. Silva B, where there is some early limited destructive invasion, which is less than a 4x field or 5 mm in diameter, it is more or less similar to pattern A at LOPA and may or may not have LVI. Silva C has an extensive and diffuse destructive invasion. It's extensive desmoplastic stromal response, high nuclear grade with or without an LVI. Now, what else is new in cervix pathology? This is not very new, but we know that till 2009, the FIGO staging for cervical cancer was based mainly on clinical examination. In 2018, the approach has been revised to allow imaging and pathology findings where available to assign stage. So this is the revised staging for cervical carcinomas, and this is a comparison with the 2009 FIGO staging. The salient changes are that if you see over here, that the horizontal dimension, that is the width, is no longer used or considered in defining the upper boundary in stage 1A cancer. So the width has been removed. We can also see that stage 1B has been subclassified into 1B1, 1B2, and 1B3 based on the maximum tumor size. And there is a new entrant that is a stage 3C, which is a new substage, and this includes the nodal status. So the presence of nodal involvement in a tumor of any size upstages to stage 3C. It's 3C1 indicating pelvic lymph node involvement and 3C2 indicating para-aortic lymph node involvement. So the conclusions from today's talk is that with the movement towards ubiquitous HPV primary screening and increasing coverage with the HPV vaccination, the prevalence of HPV-associated cervical cancers is predicted to decrease. So if the HPV cancers are decreasing, the clinicians must be aware that the HPV-independent adenocarcinomas are likely to increase as a proportion of the total diagnosed cervical adenocarcinomas. But there are advances in histopathology, immunohistochemistry, and molecular genetics, and they have increased our understandings of the spectrum of the newly described gastric type and other rare types of HPV-independent adenocarcinomas that I described, that is the gastric type, the mesonephric type, the clear cell type, etc. Now, the clinical outcome and prognosis of HPV-independent adenocarcinomas is worse, and that we need to remember, and that's why these tumors are important, than the HPV-associated adenocarcinomas. However, there is a paucity of evidence-based guidelines tailored to the management of these HPV adenocarcinomas, and this should be a topic or an area of future research. So I thank you all for a patient hearing and to take any questions.
Thank you for your brilliant presentation. Our second speaker, Professor Jillur Rahman, Professor, Department of Pathology, Bangabandhu Sheikh Mujib Medical University. He will enlighten us with his presentation, Histological Spectrum of Cervical Lesion, Research in Bangladesh, and Future Scope. Professor Jillur Rahman.
I am sharing my topic. Is my screen visible?
Sorry, screen is visible, sir.
Thank you very much. Chairperson, chief guest, panelists, and the audience, thank you very much for inviting me to present the paper on histopathological spectrum of cervical lesions, researchers done in Bangladesh. Before going to my topic, I like to thank Dr. Dibba Midha for her nice deliberation regarding the elaboration of the morphological and immunohistochemical features of different aspects of cervical lesions. So, you know, in Bangladesh, there are yearly about 10,000 new cases coming with the cervical cancers, and fatality is about 6,000. And globally, it is 5,70,000, and fatality is 3,11,000. It is the second most prevalent malignancy in women and the main cause of cancer-related fatality in Bangladesh. So histopathological diagnosis can provide information and structural changes and may guide appropriate treatment strategies. So cervix is prone to a wide range of lesions, benign, pre-malignant, and malignant. Histological evaluation is crucial in the diagnosis and management. You have already seen that there are precancerous conditions, cervical intraepithelial neoplasia, which is characterized by the abnormal growth of cells on the surface of cervix, which is divided into CIN 1, 2, and 3. Can be diagnosed by pap smear or colposcopy and should be confirmed by the cervical biopsy. So you will find loss of normal cell architecture, dysplasia or cellular atypia, nuclear changes, hyperkeratosis and parakeratosis, loss of polarity, and intact basement membrane in case of CIN. WHO classification shows there are different kinds of carcinoma, as discussed earlier also: squamous carcinoma, adenocarcinoma, adenosquamous carcinoma, neuroendocrine carcinoma, small cell carcinoma. Some common features include invasive growth, abnormal cellular architecture, loss of polarity, tumor necrosis, inflammatory response, and metastasis. The morphologic features of cervical carcinoma vary depending on the type and stage of tumor. I am skipping these parts. There are several other types of lesions except the CIN, squamous cell carcinoma, and adenocarcinoma. There are ASCAS, AGC, benign cervical polyps, and some other sarcomas also. So colposcopy, pap smear, HPV testing, and biopsy are frequently used in combination for the screening and diagnosis of cervical abnormalities. So in this picture, we are showing the mature normal cells, superficial, intermediate, and the cervical cells are seen as we see in the cytology. And these are the, you can see there is ASCAS, there is some nucleus is somewhat enlarged, and there is perinuclear halo. This is ASCAS. This is ASCH, where there is nucleus is much larger, and in case of LC, you can see this is large nucleus and perinuclear cavitations. And in case of HCIL, you will get stippled and enlarged nuclei. And in squamous cell carcinoma, we get tumor cell and clinging diathesis. So in histology, it is somewhat different from cytology. So if we see in histology, it is the normal squamous epithelium, as we see. But in case of CIN1, the lower 1/3, there is some nuclear abnormality is seen. And in case of CIN2, we see the lower 2/3 area has got loss of polarity and enlarged nuclei. But in CIN3, we see full thickness involvement of the abnormal cells. And in case of invasive squamous cell, we see there are some nests of cells which are invaded, crossing the basement membrane. So there are a number of research works have recently been carried out in Bangladesh to investigate the histological range of cervical lesions. This one is International Journal of Research in Medical Science, published in 2023. Siddiqui SRA et al. I am also one of the. The title was Diagnosis of Cervical Lesion by Colposcopy via Pap smear test and their correlation with histopathology in tertiary level, Chattogram, Bangladesh. So there 143 cases were included, and via test was positive in 98 cases, that is 68.5%. On colposcopy, most of the cases show neoplastic proliferation, 55.9%. Among them, most are CIN1. 63 cases were non-neoplastic and cervical biopsy was taken in 48 cases. Of them, CIN1 was 20 cases, 14%, and there were 2 cases were squamous cell carcinoma and 1 case of adenocarcinoma. Association of colposcopy finding with the histologic diagnosis was significant. The sensitivity of diagnosis of cervical malignancy by colposcopy was 33%, and specificity was 98.57%. Another publication in the Cytojournal in 2011 titled as Pattern of Epithelial Cell Abnormality in Pap smear, a clinico-pathological and demographic correlation, Urmila Bonik et al. I was also co-author here, and a total of 1,699 patients underwent Pap smear examination. Specimen adequacy and reporting were assessed according to the revised Bethesda system, and women aged 45 or above harbored the bulk of pre-malignant and malignant lesions in the Pap smear, signifying that these women are among the under-user of cytological screening. There is another study, prognostic impact of histopathology in patients with advanced stage cervical carcinoma treated with radiotherapy. It was published in Journal of Bangladesh College of Physician and Surgeon, and it is written by Hossain et al. Another publication, evaluation of conventional Pap test for cervical intraepithelial lesion and cancer in a tertiary hospital of Bangladesh, published in Chattogram Mao Shishu Hospital Medical College Journal. A total of 550 women underwent a Pap smear examination followed by colposcopy. Among them, 104 were NILM, 64 were CIN1, 19 were CIN2, and 8 cases were found squamous cell carcinoma. There is a study regarding HPV, high-risk human papilloma virus type 16 and 18 infection in the cervical lesion of women with epithelial cell abnormality in Pap smear. A cytohistomorphologic association in Bangladeshi women. It is also written by Urmila et al. And I am also one of the co-author. This study shows 139 women revealed epithelial cell abnormality. Routine histopathology was done on 48 cases. HPV type 16-18 by PCR technique was evaluated in 47 cases. HPV type 16-18 infection was detected in 40.42% cases. The finding of this study contribute to HPV 16-18 knowledge in Bangladesh that was useful in assessing the success of current vaccine with limited type spectra and augmenting cervical cancer screening strategies. Individually, type 16 and 18 were positive in 7 cases each, and dual infection with type 16 and 18 were seen in 5 cases. CIN1 lesion showed 18.75% and 35% positivity in HPV type 16 and 18 respectively. CIN2 lesion revealed positivity of 81.8%. 80% HPV 16-18 positivity was seen in women of less than 30 years of age. The next publication, Asian Pacific Journal of Cancer Prevention, written by Ashrafun Nisa et al. In 2013, comparison between visual inspection of cervix and cytology-based screening procedure in Bangladesh. They included 650 women. They found 74 were via positive, 8 had abnormalities in their Pap smear report. In colposcopy, 38 had different grade of CIN and 4 had cervical cancer. In histology, 20 women had CIN1, 4 had CIN2, 14 had CIN2-3, and 4 cervical cancer. Among the 38 histology diagnosed abnormalities. Via test could identify 30 abnormalities, including 2 cervical cancer. International Journal of Gynecology and Obstetrics published paper, Cervical Cancer in Low-Income Countries, a Bangladeshi Perspective, written by Muhammad Rizwanul Haq et al. They emphasize the potential of VIA as a cost-effective screening approach. Bangladesh Medical Research Council Bulletin in 2020 published a paper, Correlation of Pap smear and colposcopy in relation to histopathological findings in detection of pre-invasive lesion of cervix in Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh, written by Nouri Ferdows et al. Sensitivity of Pap smear for detecting lesions above LCL was 11, specificity 68%, and positive predictive value was 94%, negative predictive value was 71%. The incidence of pre-invasive lesion, that is LCL and HCL, was 33.64%. International Journal of Human and Health Science in 2020 published a paper, Visual Inspection using acetic acid and Pap smear as method of cervical cancer screening, and experience of Dhaka Medical College Hospital, Dhaka, Bangladesh, written by Abu Sadat Muhammad Nurun Nabi and Tahmina Sultana. 600 women screened on via 46 had white lesions and on Pap smear. 28 had ASCAS, and worse lesion out of 22 were positive on both VIA and cytology. 24 were positive on VIA only. 6 were positive on cytology only. Specificity of VIA was 97% and Pap smear cytology 98.58. Another paper was published by Muhammad Ghulam Mustafa et al. Histopathology of cervical cancer and arsenic concentration in well water and ecological analysis. They also have discussed about the arsenic being involved in the cervical cancer. Journal of Armed Forces Medical College, Bangladesh in 2017 published correlation of HPV DNA test with cytology and histology for the diagnosis of cervical cancer and precancerous lesion in a tertiary care hospital in Bangladesh, written by Islam et al. Among the 99 cases, 28 cases were positive with hybrid capture tool, HC2 assay. Out of 60 cases of CIN1, 7 cases were positive with HC2. Among others, 3 cases of CIN2 were positive in HC2. The viral load was very high in invasive squamous cell carcinoma cases, in contrast to other categories of histologic and cytologic diagnosis. A significant relationship was observed between HC2 and histological diagnosis and between HC2 and Pap smear. They concluded that introduction of HC2, where possible, along with Pap smear, would be highly effective in primary screening and subsequent follow-up of the cervical precancerous and cancerous lesions. Bangladesh Journal of Obstetrics and Gynecology in 2018 published another article titled Effect of Human Papilloma Virus Infection with Pre-Invasive Cervical Lesion, Bangladesh Perspective. The result is also similar to the others written by the Mita Juardar et al. They also says that HPV DNA test can be used as a co-test with colposcopy for screening of cervical lesion. BSMMU journal in 2013, Jannatul Firdaus et al. Published presentation of invasive cervical cancer in Bangladesh. Maximum patients were in stage 2 and majority of the patients presented with abnormal bleeding. Exophytic growth was found in the majority of the patients. Squamous cell carcinoma was more in the majority of patients, and adenocarcinoma was more in younger age group. Advanced stage of the disease at presentation and the peak incidence was observed at 36 to 45 years age group. Some other publications titled Present Status of Cervical Cancer Screening in Bangladesh by Nessa et al. Evaluation of colposcopic and histopathological findings in precancerous cervical lesion, that is written by Darji et al. Prevalence of cervical intraepithelial neoplasia at Khulna division of Bangladesh, published in Bangladesh Journal of Obstetrics and Gynecology, written by Afroza Khanam. Partha Basu, a renowned gynecologist of Kolkata, in collaboration with Bangladesh, published Evaluation of the National Cervical Cancer Screening Program of Bangladesh and the formulation of quality assurance guidance. Another article titled Comparison between Visual Inspection of Cervix and Cytology-Based Screening Procedure in Bangladesh was published in the Asian Pacific Journal Cancer, written by Ashraf Nessa. Prevalence of cervical, it is, I have also discussed it earlier. Histopathology of cervical cancer and arsenic, it is also discussed earlier. So these were the publications I have seen, and there are many others I have left because of time constraints. Thank you very much.
Thank you. Thank you for your brilliant presentation. Now I am requesting our chief guest, Professor T.A. Choudhury. He is eminent past president of Gynecology Society of Bangladesh and first president of OGSB and SAFO. Now I am requesting to give your valuable speech of today's session.
Thank you, Kashifa. First of all, I would like to apologize for being late in joining this meeting. Actually, I was having difficulty in the link. I could not open the link properly, and then I have to switch on to my mobile phone just to get into the meeting. As you see, the delineation is not very good. But in any case, I think it is a very important meeting today because the agenda for discussion is very important. Cervical cancer is a big problem in any developing country, and more so in case of Bangladesh. And we all know that apart from visual inspection of the cervix, ultimately the accuracy depends on more clear delineation of the lesion, either by Bayer test or leukocytin, or even by magnification by a colposcope. But the ultimate court of appeal is histology. Only histology will give somebody a diagnosis of correct cervical lesion. We see many ugly cervices, but when we go for histological examination, many of them turn out to be cases of chronic cervicitis, not malignancy. On the other hand, an apparently normal-looking cervix can ultimately turn out to have either CIN or actually even early invasive cancer. Cervix is an organ which is so easily accessible that there cannot be any excuse for not doing a biopsy in cases where it is required. Do not want that it should be a universal procedure for doing even small lesion, but because sometimes we are now promoting the see and treat motto for treating cervical lesions. But I think wherever there is even a slight doubt histology must be done. And nowadays, as we have known, the classical histology of staining by hematoxylin eosin is being replaced by immunochemistry plus lots of other techniques which give you much better delineation and prognosis depending from the histological examination. So that is important. As regards the today's session, I think combination of the research work that has been done in Bangladesh up till now is very important. And this conference or this meeting, I think, will give us an impetus to accumulate all the research papers which has been published up till now. Because people often complain that people in this country do not do any research. But we find that quite a few quality research paper has already been published. Only thing I think regarding the extensiveness of cervical lesion, I wonder that most of these studies have been a single center study. So if multicentric studies could be done, you get a large number of patients, the results are more authentic and so on. So I hope in future the researchers will pull their talents together and do multicenter studies more commonly than before. And in that case, they will accumulate a large number of cases over a short period of time. And that will give you a more statistical valid result. So in any case, thanks to the speakers for today's deliberation, and I hope we will continue. I'm sorry for being late, but in any case, thank you very much for inviting me to join this important meeting. Thank you very much.
আনমিউট করেন কাশিফা আপা, শোনা যাচ্ছে না।
Thank you, sir, for your valuable speech. Now I am humbly request Dr. Joydev Bhomik. He is Senior Consultant, Department of Gynae Oncology, Tata Medical Center, Kolkata, to give your views regarding today's CME session.
Thank you very much, Kasefa. And histopathology always fascinates me. I mean, this is the foundation of whatever we do, and understanding the basics, I think, is most important for all of us, to us who are clinicians and make treatment. So as Divya started by saying that, of course, the new classification has come. And until now, we do not know what difference it would make whether we know that these are HPV positive or HPV negative. But it is the right time that we actually know the classification, start differentiating between those who are associated with human papillomavirus infection and those who are not. And the reason is that HPV vaccination is coming in a big way. Of course, the incidence of cervical cancer will dramatically go down, but it will not be completely eliminated. And the reason is there are incidences of cervical cancer which are independent of HPV lesion, and that will continue. So this is now this is the time for us to do more research, get more knowledge about the outcome and the mode of treatment that we do for those patients who are HPV negative. It is more important now that because the vaccination is coming, so HPV infection will go down a very large extent. What will remain of cervical cancer is those which are HPV independent, mainly the adenocarcinoma of the cervix. It is increasing, the incidence is increasing, so we need to pay more attention. We need to be able to differentiate between the cervical lesion and an endometrial lesion. That's of primary importance. And even we need to know the exact treatment of patients. If we start researching now of the different treatment outcomes between the HPV positive and the HPV negative patients, and of course we will be able to find out more ways of treating the HPV negative patients. So thank you, Divya, and thank you, Dr. Rahman, for enlightening us with the knowledge of
Thank you, sir.
of the new things that is happening in cervical cancer, and this will go a long way in the future. We do not know doesn't mean that it doesn't exist. It exists. We're just finding it out, and of course, it will be now up to the clinicians to define different treatment options for HPV positive and HPV negative lesions. Thank you.
Thank you, sir. Thank you for your valuable speech. Now we like to move forward to our second event, question and answer session. I cordially welcome the moderator, the most exciting part of the session, Professor Sabira Khatun, President, Gynae-Oncology Society of Bangladesh, to moderate the session.
Thank you. Thank you, Dr. Kashifa Khatun, for inviting me to moderate this exciting session. I welcoming our learned panelists for this question answer session. First of all, we have the panelist, Professor Laila Arjuman Banu. Professor Laila Arjuman Banu, Madam, I would like to give some comment about this thing that sometimes hysterectomy, many times the hysterectomy done without any cervical evaluation. And we have come to know from previous two speakers' presentation that cervical evaluation and to know the histopathological diagnosis of cervical lesion is very important. And what is your message to the juniors regarding this malpractice? Professor Laila Arjuman Banu, Madam.
Thank you, Professor Sabira, for asking me the question. Actually, I am very much delighted to join this session, and also thank GOSB for allowing me to join the session. First of all, I must congratulate Dr. Dibba Mida for her excellent presentation. It was very clear, and we knew many things from her presentation. Also, I must congratulate Dr. Zillur Rahman for accommodating all the information regarding this research studies. So, cervical cancer, we all know. I'm not going in the introduction. But, sometimes I found that the hysterectomy is done without any cervical evaluation, like fibroid uterus, that adenomyosis, AUB. Even simple specular examination is not done, because I don't know whether just with only one indication they are doing the hysterectomies, but they must see the cervix. Because sometimes we see that after the operation, when histopathology comes out, histopathology report we get, there is some cervix stage 1 or the adenocarcinoma of the cervix, which is just a barrel-shaped cervix, but from the outside it is very difficult to diagnose. But they are not doing the speculum examination, which should be authentic and which must be obligatory. Because another my message to junior colleagues that you must do the PV examination even in case of bleeding PV. Sometimes they are telling that due to the bleeding we could not examine the cervix. But I found one patient, her vagina was full of with the cervical polyp, and she told that she never examined by a doctor to just PV examination because she's bleeding for the year. So sometimes we should do the PV or speculum examination even there is bleeding to diagnose and to proper management of the patient. So otherwise the treatment will be under treatment, because if there is cancer cervix, then the radical hysterectomy is indicated, and also and I now feel that the proper message should go to the junior doctors, because sometimes they are not in fault, but proper message should be done. Then how and when to diagnose the patients and when to refer the patient to a senior colleagues or a tertiary hospital. So I think this is the message we should convey to our juniors, because without any cervical evaluation, they should not do the hysterectomy. I am repeatedly telling that should not do the hysterectomy without the cervical evaluation, which is very, very important. Thank you very much.
Thank you, Professor Laila Arjuman Banu, for your nice and elaborate message to our junior doctors. I hope this will be very benefited by your message. The junior doctors will be benefited. Now, my second panelist is Professor Ghulam Mustafa. Professor Ghulam Mustafa, are you here? Professor Ghulam Mustafa.
Assalamu alaikum, Appa.
Yes, thank you very much. You are very punctual in the webinar, in our webinar. Thank you very much again. I want to know from you about the histopathology services in our country is not up to the mark, especially from Dr. Divya Midha's presentation. My feeling is that the histopathology service in our country is not up to the mark. So how we can improve the situation, how the histopathology report can be improved, and how the number of histopathologists in our country can be improved, and how the experience and skillness of the histopathology.
ম্যাডাম আপনি মিউট হয়ে আছেন।
Oh, sorry. Sorry, Professor Ghulam Mustafa. Again, I have to say the question. As a senior histopathologist in our country, my question to you, the histopathology services in our country is not up to the mark, especially from Dr. Divya Midha's presentation. My feelings is that our histopathology report is not up to the mark. Then how we can improve the situation? Histopathology service can be improved in our country, and how the number of histopathologists can be improved, and how the services of histopathology in the peripheral district hospitals or peripheral medical college hospitals can be improved. I think this is mandatory for our this gyno-oncology or other oncology services in this country.
Thank you, Professor Sabera. Histopathology service in our country is not up to the mark. That means the other services of our country is up to the mark. Only histopathology service is not up to the mark.
Not that,
actually,
maybe other services are not up to the mark. They are now concerned with histopathology services.
Yeah. Now, actually, histopathology service, it starts from the surgeon. Surgeon, when does operation, actually it generates a sample, and then there are issues with sample collection, sample orientation, sample marking, sample preservation, sample transportation, then writing requisition, and some other practices we usually find in our practice, such as fragmentation of the sample, division of sample, all these issues. So if the sample quality is not good, then it is very difficult. If preservation is not good, it is very difficult for us. So these are actually pre-analytic factors. So these factors is beyond our hand, because when we receive the sample, all these factors are already passed away. Now, one very important issue is substandard preservation. And substandard preservation means we know that 10% formalin is the most effective and most important preservative. But you know that formalin is banned in our country. Legally, formalin is banned. Now, if you want to use formalin, you have to have a license. And even the vehicle by which you will carry formalin, you will have to license for that vehicle also. And I can assure you that this law was made about 20 years, not 20 years, about 10 years back, not 10 years, about 16 or 17 years back. This law was passed when there was a hue and cry that all the fruits are preserved by formalin. So there was a massive movement and massive media crisis. So government banned formalin. So they have written in that law an option that those who want to use formalin, they will have to have license. And till now, no one would able to get that license. So how formalin is, how we are dispensing formalin and how we are using formalin. So all are smuggled. So formalin is coming in our country with other declaration, and the shopkeepers, they are selling under other name. So even if someone carry formalin in the road, and if police can pick up that, he will be punished. So the shopkeeper, what they do, actually, they will tell you that it is formalin, but on the container, they will write that it is distilled water. So you will have to buy formalin as distilled water. And what they do, they usually dilute the formalin. So why they dilute the formalin? To reduce the smell of formalin. Because if the pungent smell is there, and if police can easily identify that it is formalin. So these are the issues. So you are using formalin that is not more than 1 or 2 or 3%. It is not 10%. So most of the specimens, they are under preserved, they are autolyzed, they are poorly preserved. We frequently write that this specimen is poorly preserved. So with poor preservation, we cannot report it properly. Now the analytic phase, you see, we have a serious lack of technologists. In our country, we don't have really technology training school. We have several technology training institute, one in the government sector in Mohakali, and there are many in the private sector. Now that government technology training institute, it is not attached with the hospital. So they learn only theoretical, only theory. So when a graduate technologist comes to us, he knows nothing. So we have to actually prepare our technologist. And you know that it is very difficult job. And in our country, when I prepare a technologist, after 5 or 6 or 7 years, he goes to somewhere else. So that is very important factor for us. And not only formalin, the same issue is true for 28 chemicals. All the acid, all the alcohol, all other, in total 28 chemicals are banned. So the same situation of formalin is true for all those things. Even the government institute, they are publishing tender in daily newspaper for these banned items. They are buying also. We are doing the same thing. So nobody is looking at that. So there is a quality compromise. So, and another issue is very high tax in the reagents and chemicals in our country. In India, the highest tax is 30%, but here tax is up to 70%. So that's why our cost is also high. Now, the post-analytic phase, number of pathologists. You know, we have less than 300 pathologists in the whole country. We have an association, Bangladesh Academy of Pathologists. Its member is 288. So we are facing serious shortage of pathologists. Now, the quality of pathologists. You see, who are the pathologists? Basically, they are MBBS doctor, and we now know about the situation of our MBBS doctor. So the quality of MBBS doctor, we all know. So they are entering into the courses, and the top graded doctors, they are not entering into the pathology because they are not interested in pathology. So the backbencher type of doctors, they usually enter into pathology because they think that there is lack of recognition. There are some other factors in the job sector. There are some demotivated issues. So with all these issues, the pathologists are they cannot come up. And the most important thing is the training institute, the level of training offered by the training institute. At present, there are 8 places where the pathology post-graduation courses are available. And in most of the places, except BSMMU and some institutes in Dhaka, they are facing serious crisis of teachers. They are facing serious crisis of samples. And believe me, when we take exam, I frequently ask how many ophthalmic cases you have seen. The answer is none. How many lung specimen you have seen? The answer is none. How many gastrectomy sample you have seen? 1 or 2. So this is the standard of training at present, because we have decentralized the course into different places. In those places, there is no expert pathologist, there is no teacher. There are some places where only one teacher, and there are 10 or 15 or 20 pathology residents. So these are actually problems. Now, as we are running the Bangladesh Academy of Pathology, we actually are trying to fill up some of the gaps. We are regularly organizing CME, slide seminar, conference, and different types of workshops. So those things are, I think those are not enough, but still we are trying. And I would like to request Professor Jillur to look at these points to improve the quality of training. And look, actually, we have to find a way of, actually we are placing these doctors in a desert. So we should think about that. And as Professor Jillur is the key person of this academic activity and these courses, I would like to bring these issues to his knowledge. Thank you very much.
Thank you, Professor Ghulam Mustafa, for your very vivid and very elaborate elaborate discussion about the situation of Bangladesh. We have come to know about the matters which I think many of your colleagues do not know these things. Thank you very much. And we also did not know these things. We are very much benefited, and thank you very much. Now, our third panelist is Professor Rehana Parveen. Professor Rehana Parveen, are you here? Professor Rehana Parveen?
Yes.
Thank you very much for waiting for a long period. Now, sometimes the histopathology report do not correlate with the clinical examination findings. You know, that sometimes we do not find any correlation between the clinical examination findings and the histopathology report. Which one you prefer for confirmation of a diagnosis? Immunohistochemistry test or repeat biopsy?
Thank you very much for the question. I can say that here, the indication of repeat biopsy and immunohistochemistry are different. Repeat biopsy is indicated when there is discrepancy between clinical findings and biopsy report. Say, for example, there is an obvious growth in the cervix, but biopsy report says it is dysplasia. So repeat biopsy is done by an expert to take tissue from a proper site for confirmation of the diagnosis. But it is not the same case with immunohistochemistry, which is indicated to confirm the site of origin of the disease when there is histopathological overlap. Say, for example, when there is doubt whether the case is an endometrial adenocarcinoma or endocervical adenocarcinoma. There is no confusion about the histopathological diagnosis, but we don't know the site of origin of the disease. And so to know the exact site of origin, immunohistochemistry is important. In this situation, we can do ER, PR, P16 and vimentin. If ER, PR and vimentin are positive, we can say that it is a endometrial adenocarcinoma. And if P16 is positive, we can say it is endocervical adenocarcinoma. So there is no problem or the problem with the histopathological diagnosis, but only the site of origin of the disease is not known. So to know the site of origin of the disease, we have to do the immunohistochemistry, because treatment is entirely different in case of endometrial adenocarcinoma and endocervical adenocarcinoma. So for confirmation of the disease, sometimes it will be needed immunohistochemistry and sometimes it is repeat biopsy, but the indications are different. Thank you very much.
So thank you very much for your clear conception about the immunohistochemistry and repeat biopsy or review of biopsy report. We always sometimes face these problems. Now, our last panelist is Professor Farida Arjuman. Farida Arjuman, are you here? Please, are you here, Professor Farida Arjuman?
Assalamu alaikum, madam. Yes, I'm here.
Yes, thank you very much. For the treatment of cervical pre-invasive disease, we need very critical classification like CIN 1, 2, 3, carcinoma in situ, microinvasion. These are very critical classification of cervical pre-invasive and R-invasive disease, and which can only be diagnosed by histopathology only. And what type of problems you face in giving these reports on pulse biopsy specimen? How can it be improved?
Thank you very much, madam. And assalamu alaikum to all learned and respected teachers of mine and all the senior colleagues. Before answering the question, there will be a little bit correction. I'm not the professor. I'm serving as the associate professor. and head of the Department of Histopathology in NICRH. So regarding the issues of punch biopsy, that is colposcopic biopsy of cervical specimen, in our setting, that is in the NICRH, and in our private setting, there are two different types of problems we are facing. Lots of issues are there, say, the most important one is specimen adequacy. Most of the time we see there is inadequacy of specimen, or there is, it will be admixed with the bloody sample or necrosed tissues, friable tissues, and mixed with the mucus. And there is poor preservatives, as already Professor Ghulam Mustafa sir said. We are facing the most difficulties regarding this issue, and misleveling. If we mislevel the tissue, that is also another issue, and inadequately and improperly filled requisition form. Other than these, there are some other issues, say, in case of small biopsy sample, we fail to reach the diagnosis regarding the deeper cut of tissues. Say, in superficial cut, there is CIN 1 or 2, but whenever we go for the deeper cuts, there will be some sort of microinvasive or CIN 3 like this. Other than this, there are fragmented specimens, and also in case of uncommon malignancy, whenever we have to address the uncommon malignancy, in those cases, we have to go for a large volume of tissues for confirmation. So these are the issues from the clinician side. And another very important issues we are facing in the private sector. Whenever there is a hysterectomy, they have cut down the specimen, just small portion of cervix, they send to the histopathologist for reporting. So we saw there is a cancer or invasive or stromal invasion. We cannot comment about that. We cannot comment about the grading and staging with this small amount of tissues. And from the laboratory side, other than the clinical side, if there is we are facing difficulties in processing the specimen regarding the orientation of the tissues. So these are the main issues we are facing in our day-to-day practice.
Thank you. I want to ask you another question. Whether for the diagnosis of invasive cervical cancer, if there is frank growth or ulcer in the cervix, whether punch biopsy is sufficient, or we should take a more tissue waste biopsy or more large tissue. Whether my main concern is whether when we see a growth in the cervix, whether punch biopsy is sufficient, because sometimes I see that from the growth, the tissue is taken by the punch biopsy for SIP. Is it sufficient to give the opinion about the invasiveness of the disease?
Sometimes this is not sufficient because we cannot see the epithelium. So for comment on invasive carcinoma, we have to see the baseline epithelium along with that. We receive the bloody sample or necrosed tissue. Along with that, some focus of components, that is malignant components, are there. We can say squamous cell carcinoma or grading like that, but for invasiveness, we have to see the epithelium along with that.
So what is your advice? We should not take a punch biopsy for diagnosis of a invasive cancer.
Not that, because most of the cases we can diagnose, they do not miss. But if we consider the percentage in that case, say if it is 100 out of 100, say 10 to 20% cases we missed the diagnosis for invasiveness.
So I think as far as possible, we should take a bigger tissue for histopathological examination. Thank you very much. So thank you all the panelists for their nice and elaborate discussion and question answer. Thank you very much. Now, Professor Dr. Kashifa Khatun, you can go for the next part, last part of our session.
Thank you. Now I would like to request Professor Jannatul Firdaus, she is Scientific Secretary, Gynae-Oncology Society of Bangladesh, and Professor, Gynae-Oncology, Department of Gynae-Oncology, Bangabandhu Sheikh Mujib Medical University, to give vote of thanks and conclude the session.
Can you hear me? Can you hear me, Dr. Kashifa?
You are hearing. শোনা
Thank
যাচ্ছে।
Thank you. Honorable Chairperson of today's CME, Honorable Chief Guest, invited speakers, panelists, all teachers, participants, Assalamu alaikum and good evening. It's my privilege to have been asked to deliver a vote of thanks on this occasion. I, on behalf of Gynecology Society of Bangladesh, extend a very hearty vote of thanks to our respected chairperson, Professor Sabira Khatun Madam, who has given us a constant support, encouragement, and guidance. I'd like to give special thanks to our chief guest, Professor T. Choudhury, sir. Your presence has graced our occasion. Thank you, sir, for accepting our invitation and for being with us till this late hour. I must mention great appreciation to Dr. Divya Mitha and Professor Jilur Rahman for giving excellent coverage and overview of histopathological spectrum of cervical lesions and researches. I also wish to express my gratitude to the respected panelists for their in-depth discussions. We are all inspired by your great words. And finally, I would like to acknowledge and show gratitude to the Secretary General, Moderator, all members of GOSB, and to all the participants, without whom today's CME would have been incomplete. At last, but not the least, I thank Opsonin Pharma for their scientific support and also Doctors TV as media partner for GOSB. Thank you all.
Thank you. Thank you for being with us.
Thank you all.
Thank you so much for having me. Good night.
Thank you, Dr. Divya
Thank you, Dr. Divya. We will invite you again to our next sessions.
I will attend with pleasure.
Was very much informative.
Thank you so much. Thank
Yeah.
you.
Up করে দেন।
শুনতে পাচ্ছেন?